Well, good afternoon, everybody. This is so exciting. I can't believe how many people are here. This is probably the biggest crowd I've ever spoken with. Maybe not, but I just want to start by thanking everyone at the James Weldon Johnson Institute for the study of race and difference, especially Kalia Asset. She called me last year and invited me to present at this colloquium series. And when she called me, I was just really starting this research, and she said, well, why don't you come next year? And so here I am, and I'm really honored to share with you this work and engage in the questions and feedback that you have, because it is very new work for me. So just a little bit about myself. I'm an associate professor now of sociology, and so I'm in the history of the School of History and Sociology in the Ivan Allen College of Liberal Arts. And I study the sociology of medicine, health, science, and technology. And for at least the last 10 years or so, I've really focused on the scientific and the social implications of viewing autism through a genetic and increasingly genomic lens. And so my recent book, called Multiple Autism, Spectrums of Advocacy in Genomic Science, really maps out the social history of parent advocates and the work that they did to really put autism genetics research on the map, the optimism that scientists had for finding the elusive gene for autism and the subsequent failure, and different ways they started viewing autism through a genomic lens, and also the various meanings attached to autism in the context of knowledge produced through genomic technologies. And if you're interested, I do have a couple of books that I'm happy to share with you, and there's some flyers about as well. A central finding of that research was the ways in which biomedical frameworks tend to obscure the social and the structural forces that shape how people experience autism and their ability to navigate services. Most notable among barriers facing those with autism and their families is the difficulty in securing diagnosis, the lack of guidance given to parents after they're given a diagnosis, or after their child is given a diagnosis, and the limited resources available for subsequent services, particularly for families with limited resources. And the families from my first study were predominantly living in Georgia. So in the spirit of James Weldon Johnson, for which this colloquium series honors, and who was a poet among many of his talented gifts. I want to start with a poem written by Emily Pearl Kingsley. It's called Welcome to Holland, and some of you may have heard it. I'm often asked to describe the experience of raising a child with a disability, to try to help people who have not shared that unique experience, to understand it, to imagine how it would feel like. It's like this. When you're going to have a baby, it's like planning a fabulous trip to Italy. You buy a bunch of guidebooks and make your wonderful plans, the Colosseum, the Michelangelo David, the gondolas in Venice. You may learn some handy phrases in Italian. It's all very exciting. After months of eager anticipation, the day finally arrives. You pack your bags and off you go. Several hours later, the plane lands. The stewardess comes in and says, "Welcome to Holland." Holland, you say? What do you mean Holland? I signed up for Italy. I'm supposed to be in Italy all my life. I've imagined going to Italy. But there's been a change in the flight plan. They've landed in Holland, and there you must stay. The important thing is that they haven't taken you to a horrible, disgusting, filthy place full of pestilence, famine, and disease. It's just a different place. So you must go out and buy new guidebooks, and you must learn a whole new language, and you will meet a whole new group of people you would never have met. It's just a different place, a slower place than Italy, less flashy than Italy. But after you've been there for a while and you catch your breath, you look around and you begin to notice that Holland has windmills. Holland has tulips. Holland even has Rembrandts. And the pain of that will never, ever, ever go away, because the loss of that dream is a very, very significant loss. But if you spend your life mourning the fact that you didn't get to Italy, you may never be free to enjoy the very special and the very lovely things about Holland. So in my first research study on autism, parents shared this poem with me several times, and it circulated among different groups. In one of my home visits, I recall seeing a copy of this poem posted on the refrigerator door to remind parents of the changes surrounding their life, but also the possibilities for the future. And although this poem offers hope and insight for parents of a child with disability, it represents a dominant voice in the U.S. that often makes many assumptions. First, such as having the resources to travel to the desired destination, as Italy, the ability to buy new guidebooks, the time to actually learn a new language. It also assumes that such resources are made equally available in order to experience the beauty of an alternative destination. Furthermore, it represents the predominant face of caregivers of children with disabilities, which for autism has been represented as white, middle-class married couples who often have time, money, and resources to achieve an early diagnosis, and the expensive and time-consuming therapies that may have a difference in the life trajectory of their child with autism. And so, for example, primetime television shows such as Parenthood, some of you might be familiar with this, featured an upper middle class family with a child with Asperger's, which is a less severe form of autism. The storyline portrays a stay-at-home mother who is able to fiercely advocate for her son and cut through the long wait list to see a specialist by asserting her social and her cultural capital. The story's season finale showcases these parents as starting a new school for children with disabilities so that their son could receive the best possible education. The executive producer of the show, who has a son with autism, stated that the portrayal was meant to capture how parents deal with having a child on the autism spectrum and everything that they have to go through. In scholarly research, including my own, as well as autobiographical accounts of parenting a child with autism, there are also representations of mothers as warrior heroes who engage and fulfill the various social and biomedical accountabilities to help their children. These mothers have social and financial resources to seek early diagnosis, gain expertise and knowledge on how to help their children, and they challenge the approaches of professionals from multiple systems. Although these are voices heard in mainstream culture, they are not necessarily voices from experiences that are shaped by a structurally unequal society. As Amy Sosa asserts, waging war on autism is expensive, which requires time and money to navigate and engage in such a war. It is estimated that the cost for autism can range from $20,000 to $40,000 a year, which doesn't account for the unpaid labor taken up by mothers who typically coordinate all their child's care. So, informed by the analytic framework of intersectionality, which was developed by Black feminist scholars such as Kimberly Crenshaw and Patricia Hill Collins, I'm interested in calling attention to the centrality of white female experiences in autism parenting, and how the narrow scope of this dominant conception of parenting tends to marginalize those whose experiences cannot be described within these parameters. An intersectional approach attempts to analyze social relations and processes across multiple domains and levels of social action that are typically investigated separately, but should be looked at as interacting together. This framework challenges me to ask a new set of questions, such as, what happens when we begin to understand autism from alternative points of view, or ones that do not follow the archetype that we see in our social and cultural landscapes? What can we learn from knowledge generated through somewhat invisible perspectives with regard to structural inequalities, and how do these different ways of knowing intersect with race, class, and gender? Or again, to think about this in conversation with James Weldon Johnson, how can we lift every voice to hear the songs unsung? The songs I'm examining in this project are the ones typically silent from dominant narratives of autism caregivers, those of Black women whose multiply burdened experiences are shaped by structural inequalities, and whose voices are often marginalized, obscured, and less understood. So my talk today really engages with these questions and is situated in a larger project that I have in collaboration with Children's Healthcare of Atlanta and the Morehouse School of Medicine. And I'll talk a little bit more about that study. It's designed to take a multi-level approach to understanding the disparities of autism that exist at the intersection of race, class, and gender. So just for today's talk, what I'll do is first give you just a brief on autism and what it is, and in terms of the disparities that exist based on quantitative research. I'll then share the theoretical and conceptual model that I've designed to really think about some of these questions and how we might answer them. Briefly, I'll describe my methods that I use to generate the qualitative data that I'm going to share with you today. And finally, I'll present preliminary data to highlight narratives of structural and institutional inequalities that exist for Black women who are navigating a new landscape of autism in a terrain of limited resources and services. Specifically, I will highlight the gender politics of Medicaid. So I want to emphasize that this is very new work for me, and in fact, this is the first time I've actually presented this work. And so it's ongoing, and I just want to put that out there. And so your feedback is highly valued in anything that I present today. All right. So over the last 40 years, the recorded prevalence of autism in the United States has risen dramatically from a rare condition affecting approximately 1 in 3,000 children to a prevalence of 1 in 68 children diagnosed with what is described as autism spectrum disorder today. ASD, as it is defined by the American Psychiatric Association, is defined as a lifelong neurodevelopmental disorder characterized by persistent deficits in social communication and social interaction and restricted, repetitive patterns of behavior, interests, and activities. A trained clinician can diagnose autism reliably by age 2 or 3, and statistics suggest that it is 4.5 times more common in boys compared to girls. Recommended treatment for autism consists of early intensive behavioral and educational interventions at a minimum of 25 hours a week, 12 months a year, which can potentially result in a child's ability to participate in education, in their family, and their communities. However, many families who have a child with autism are unable to access early diagnosis of autism and subsequent services, which have been associated with social factors such as socioeconomic status, ethnicity, race. For example, most recent data generated from the Autism and Developmental Disabilities Monitoring Network, which is an active surveillance system in the United States, found that white children approximately 30 times more likely to be identified with autism than Black children, and 50% more likely to be identified with autism than Hispanic children. In other words, as reflected in this table, white children are more likely to be diagnosed with autism. Quantitative research has shown that these disparities are evident in multiple domains of autism trajectories, including age at diagnosis, representation of racially diverse students in special education, and access to early intervention and services. Although autism disparities based on race, ethnicity, and social class are persistently evident as individual risk factors, the complex milieu of how multiple social factors operate together in contributing autism disparities is less understood. Without this understanding, the goals of ending health inequalities and racism and patriarchy more broadly make it even more difficult to obtain. So as I indicated before, this research is informed by the framework of intersectionality, which conceptualizes various dimensions of inequality, such as racism, sexism, classism, as intersecting relations of power. These forces additionally create basis for identity and group status and form the foundations of hierarchical differences. Analytically, intersectionality interrogates how race, class, and gender and other social locations and inequalities operate simultaneously in social life, rather than working as a single category. Importantly, it acknowledges how power is organized, distributed, maintained, and challenged based on these intersecting social categories. As Black feminist scholar Patricia Hill Collins states, these various forms of inequality operate through racism, sexism, and other forms of discrimination that interact and intersect with each other in what she describes as interlocking systems of oppression. Intersectionality has been taken up by many different disciplines, such as public health, gender studies, social work, media studies, anthropology. Sociologists have also used this conceptual framework to investigate various axes of inequality, including health inequalities such as HIV and heart disease. These studies highlight the social context of risk and the inextricable link between health behaviors and outcomes to structural, historical, and situational context of people's lives as they are shaped by race, class, and gender. So the inclusion of gender, let's see, do I have, yeah. The inclusion of gender into this complex milieu of social and structural mechanisms related to autism care is particularly important for this study, since social science literature, feminist, and disabilities scholars typically show that mothers are the primary caregivers for their children, especially children with disabilities. The inclusion of gender in this analysis is also a unique contribution to the literature, since it has not really seriously been considered in theorizing autism inequalities in terms of diagnosis and services. As I indicated earlier, in the dominant model of autism parenting, there is an assumption that mothers have the time and resources to navigate various autism trajectories of care over time. Further, the narratives in scholarship and in the public domain are often stories of highly resourced, white, upper middle class, and married women. My research takes into account the intersecting and multiple impacts gender has for Black women, who may be navigating autism services on their own. Thus, this analysis also reveals the workings of social class as articulated through race relations, as it explores why these women may have limited time due to work commitments and or have limited resources of social, economic, and cultural capital. And so this is just a framework that I developed that takes an intersectional approach to understanding autism disparities based on 3 levels of analysis: the structural, the institutional, and the individual. I developed these levels of analysis by drawing on and elaborating Celeste Watkin-Hayes' research on intersectionality and HIV. This figure is just a conceptual framework, a methodological framework that I'm using to really take into account the intersections of race, class, and gender in these 3 levels of analysis. And on the left, I'm just kind of giving you an example of what do I mean by structural, what do I mean by institutional, what do I mean by individual. So the structural level consists of customs, practices, or laws that shape health inequalities, such as historical segregation laws, healthcare policies, special educational laws that restrict or deny access to services. For example, state programs such as Medicaid health insurance or early intervention programs such as Babies Can't Wait in Georgia could potentially shape who has access to autism services, the type of services offered, and the overall spending for children with autism. This is particularly relevant in Georgia, since we're one of the several states that did not take up Medicaid expansion through the Affordable Care Act, otherwise known as Obamacare. The institutional level is based on differential access to goods and services and opportunities to society based on the structural inequalities. So these can include material conditions such as the quality of education, safe and sound housing, appropriate medical facilities, and the ability to access power. And power can be in shapes of knowledge, it can be in shapes of representation and resources that people have. For example, families who do not have access to quality health care because of structural inequalities may miss early opportunities for a pediatrician to identify developmental delays. The individual and interpersonal level operates at a level of personal interaction, and this could be discrimination, it could be trust, it could be reciprocity, stigma, language barriers is a big one. Which can shape health behaviors and individual health outcomes. For example, research shows that African American children were 3 times more likely to receive another diagnosis before they received an autism diagnosis, and they were 5 times more likely than white children to receive a misdiagnosis of conduct disorder or adjustment behavior rather than attention deficit hyperactivity disorder. So these findings really suggest that racial prejudices and discriminations, whether they're known or not, held by clinicians can affect the probability of one diagnosis over another. as well as referral bias to pediatric assessment for autism in ethnic minorities. So as you can see from this figure, there's a lot going on, right? Makes my job indefinite. And I'm focusing today on, there's various ways in which I'm trying to think about how I can get at understanding these different levels of inequality at the intersection of race, class, and gender. But today I'm really focusing on interviews that I've conducted with parents. And I'll be sharing with you qualitative data that I've been collecting in collaboration with Dr. Leslie Rubin. He's the director of the Autism Clinic at the Hughes Spalding Hospital, a campus of Children's Healthcare of Atlanta, or CHOA. So CHOA is the largest Medicaid provider in Georgia, and at Hughes Spalding, 90% of patients are uninsured or rely on Medicaid. My analysis is based on demographic data that I collect in a quality of care survey that I'm conducting right as we speak, tomorrow, in fact. And the survey has many dimensions to assess quality of care. Barriers that people have in terms of accessing the clinic itself, like how did they get there, what was their pathway, as well as, is everything okay? As well as the quality of family-centered care and the quality of care coordination. Throughout the surveys, which can take up to 2 hours, I follow up with open-ended questions to better understand their responses, and I have a whole list of questions that I ask parents to elaborate on in terms of pre-diagnosis, while they're getting the diagnosis, and post-diagnosis to get a better understanding of their experience. So for today's talk, I'll be drawing on data from 13 caregiver interviews. Our goal is to interview 50, so I'm halfway there. And so this is just the tip of our collection of families who have participated. I conducted a systematic thematic analysis using grounded theory. This involves coding segments of qualitative data to specific categories, and I write detailed memos for categories to capture the data conceptually. The interview data was coded based on the 3 levels of analysis that I described to you. I'm learning the categories that I even created in terms of thinking about these levels of inequality. I missed a lot because parents are telling me what they're experiencing. And today I'll provide analysis of this, just in a snapshot of what a structural inequality looks like, as well as an institutional inequality that were evident in these particular narratives of Black women. So these are either mothers or grandmothers. I had 4 grandmothers in the study, and they're all raising, a child with an autism diagnosis. Given that the focus of the colloquium is on race and difference, I'm interpreting these broad and ever-changing constructs to examine how narratives embodied at the intersection of race, class, and gendered, which are embedded in structural and institutional inequalities, shape alternative and different stories compared to the dominant narratives portrayed in caregiving a child with autism thus far. So really quickly, this is just some of the demographic data for those of you who like data. It gives you just a snapshot of the demographics. I think I have 25 or 26 questions that I ask about demographics, so I'm just really trying to capture various dimensions of social class. 70% consisted of primary caregivers who were divorced and never married. 10 were mothers, 4 were grandmothers. 62% of women had a high school graduation, some college or a vocational degree. 61% of the participants rented a house or an apartment. 62% of the families had incomes of less than $4,000 a year. All the primary caregivers were English speaking, and most of them are on Medicaid. Importantly, for today's talk, half of the participants rely or have had to rely on public transportation at some point, and 61% are currently unemployed. The second chart just shows the average age of child with autism in these families, which is about 8.7 years old, and then the range. And the average age and the time to diagnosis from when the parent was first concerned. So I ask parents, when were you first concerned? And they tell me that, and then they tell me their long story to the pathway to actually either seeing someone at the clinic or somewhere else. And so we're seeing that, there's a difference about 3. But that ranges. Your mic is not on, please remember. Okay. Yes, thanks. I think I have a loud voice. Do I have an okay voice? Yeah. Raise your hand if you didn't hear me. That's never been my problem. Thank goodness, right? Okay. So these demographics and others were collected to really help to understand various dimensions of social class, which can help contextualize the risk of delayed diagnosis and limited access to services. The early concerns parents had in their children are evident in this sample. And so, parents are worried. It's not like they're, disregarding these concerns. And then the length of time it takes, as many as 8 years, is a bit concerning. And so really to help to understand these gaps more comprehensively, I'll offer some narratives that are embedded in structural and institutional inequalities. Okay, again, I want to emphasize these are preliminary results, and I have lots of data to still analyze. So structural inequalities that are evident in the data thus far circulate around issues of government systems of care, work policies, income inequality, and the quality of schools. These structural inequalities do not operate in isolation, but rather work together and interact with race, social class, and gender. As evident in the cases that I share with you today, families in Georgia must negotiate a range of federal, state, and private resources or financial resources, as well as coordinate care among numerous providers in order to access the care that they need for their children that have a diagnosis with autism. And as previously noted, all the participants in this study are women who overwhelmingly expressed that they did the majority, if not all, of the care coordination in order to get the therapeutic and educational services that they needed for their child. Even, parents, women that are married, she's like, yeah, I feel like a single parent because I do all the work myself. Government health policies, especially Medicaid, cover a limited amount of autism therapies in Georgia, which affects how many services caregivers can feasibly obtain. So for example, Tiana, a Black single mother who has 4 children, works full-time and has a 5-year-old boy diagnosed with autism. I met Tiana during her 30-minute lunch hour at work, and her most recent concern was trying to find an occupational therapist for her son. She was frustrated because all the Medicaid referrals she received from the clinic that were in her geographical location were booked and didn't even have a wait list. She stated, when I called to schedule an appointment, they said they were booked. There was no waiting list, and they didn't have anyone who could see him because I wanted later hours. For Tiana, having availability to therapy offered in the evening and closer to the home would have made it possible for her to get the services recommended for her son. The limits of services were also evident in her son's school, which only offered speech therapy once a week. Even though the autism clinic recommended that her son get at least 2 speech therapist sessions a week to help with his ability to verbally communicate. This is something that he was still working on. Even though there are other private speech therapy options outside of school and Medicaid, Tiana cannot afford them. And even if she could, she would not be able to take the time off of work because the sessions are typically offered during the day. Furthermore, she could not feasibly travel over an hour, the traffic here, right, each way to take her son to services twice a week that are available in other parts of Georgia because she has, other children to care for, and she works full-time, and she's single. For now, she goes to an additional speech therapy that is offered 1 day a month on Saturdays near her home. However, she has to take all her children to these sessions, which can be difficult since these places are really not equipped to care for siblings. Tiana's story of trying to get 2 of the most common therapies, speech and occupational, highlight how various structural inequalities, including the limited Medicaid coverage and service availability to her home, and resources to get the help her son needs. Tiana's full-time job as a janitor provides her with a stable income between $20,000 and $30,000 a year, and this allows her to rent a home and provide for her family. However, her full-time job also serves as a barrier due to the inflexibility of her work schedule, which is typical for service industry workers. Several of the women I interviewed struggle with this inflexibility of their jobs, to leave during the day to take their children to services. Having a full-time job is also constraining, especially for women who would get penalized when they have to leave at a moment's notice because they got a phone call from school. And this happened quite a lot to the parents I talked to. The limits of Medicaid in Georgia are also evident based on caregivers who have received state services from other states, such as New York and Maine. Take Alicia, for example, who is a Black, married, and a stay-at-home mom. She used to work, but got fired because of the frequent times that she had to leave to care for her 2 daughters. She moved to Atlanta with her husband and 2 daughters. One has a diagnosis of autism, the other has a diagnosis of schizophrenia. 13 months ago, after her husband lost his job in Maine. They thought Atlanta would be a good place to relocate since her sister lives here with her children. However, as she described how obtaining services through Medicaid in Atlanta are extremely difficult. While living in Maine, Alicia had access to a range of services for her daughter that came to her house directly. It just seems unheard of, such as speech therapy, and she went on, occupational therapy, physical therapy, social skills, and adaptive therapy. Her daughter also had access to a small and large groups to help with her socialization skills. All these services worked both inside and outside the public school system and coordinated together. This was extremely beneficial, especially for Alicia, because she doesn't have access to a car and has to rely on public transportation, which I'll talk about in a minute. She described how services offered in the home created a more holistic approach that not only offered services to the child with autism, but also provided parents with the tools needed to help their child in the environment that's available to them at home. Like Tiana, Alicia was also very frustrated with the amount of effort it took to get Medicaid services when she first moved to Atlanta, where many services were not available and caregivers are responsible for basically coordinating all the care, which is spread out in many locations. She stated, and it's hard to emphasize, how parents are passionate about what they're saying, so I will do my best. She stated, "It's a roadblock. Every time you're trying to get speech started, trying to get occupational started, there's a long wait list for everything. So really, I think the biggest problem is the delay in everything. You have a kid that is now going without services because everything is so delayed. And then they start having repressive behaviors because they are not keeping up with the skills that they are learning, and they're losing them." And this was her experience. Alicia went on to discuss and share with me that even when she finally secured therapy for her daughter, she has to be very careful not to go over the caps that Medicaid would cover. And I'm not certain what those are. It's something I need to learn. If she goes over the coverage, it would be hard for her to pay out of pocket for the difference. To help resolve this, she requested guidelines from Medicaid and received a thick document written in legal language, which she could not understand or comprehend. And she was a pretty smart woman, I was like, "Where is it? Can I see it?" She's like, "Oh, it's in the car or something." Another mother, Paula, who moved here from New York, also witnessed firsthand the stark differences in public services when she moved to Atlanta. She stated, I loved her presence, very passionate. "Being in the state of Georgia, they don't help you. That's the problem. That is the main issue. They don't help you. They give you 1-800 numbers that nobody answers. They refer you to people that don't want to help you, won't help you, and can't help you. So that serves no purpose." So that's a major hurdle. Paula, who was from a low-income household and married with 5 children, also lost her Medicaid insurance for her daughter because the system accidentally documented her daughter as a male instead of a female. This error was explained to them as a technical error that the state could not change. As a result, the state declined her daughter's Medicaid, and she had to reinstate her daughter again. As a part of this process, Paula had to attend a hearing to challenge and prove that her daughter was a girl. This incident resulted in a year-long gap in her daughter's coverage, which required that they pay out of pocket for her daughter's medication, which is what they had to do. As Paula stated, it's thrown everything off. So now we have to get back into the cycle. So these examples are just a sample of the structural constraints that exist for parents who have limited resources and rely on Medicaid. There are layers of complexity here, which do not point to a single barrier, but rather structural inequalities embedded in Medicaid insurance policies and services, limited inner-city public schools, many of which are racially divided in Georgia, Atlanta, flexibility of work policies, and of course, income inequality. The fragmented systems of care in the state of Georgia and the amount of work required gaining access to government programs and special educational services are structural constraints that are compounded, for low-income and Black female caregivers who are typically doing all the coordination of care with limited assistance. Families who live in South Fulton County, which were quite a few in my study, disproportionately experience many challenges finding autism services south of I-20, which is the dividing highway that cuts straight through Atlanta. Historically, which I want to investigate further, so if there's any historians who want a project, I have one. This is a dividing line segregating communities based on race and social class. In fact, the autism clinic is situated at the very intersection, this dividing line, and operates in the shadows of Grady Memorial Hospital, the only public hospital in Atlanta. All right. So institutional inequalities are related directly with structural inequalities. And for this analysis, we're among the most abundant themes that were coming in this category that I had with, that I learned from these caregivers. And I just want to highlight for you the barriers of transportation and the ways in which this institutional inequality manifests differently for low-income Black female caregivers of children with autism. The institutional constraints of transportation were a concern. I knew this before I started the study, as many of you probably realize as well. It relates to Alicia and other caregivers' criticism of how services in Atlanta are not offered in one place, and to Tiana's frustration with the far distance parents are required to travel to get to the only services that are available. Half of the caregivers in this study had to rely at some point on public transportation to get to and from autism services. I mean, how many of you take public transportation because that's your only choice, right? It takes time, right? Compounded with the constraints of Medicaid, the lack of reliable transportation limits what services caregivers have access to and the time it takes to get somewhere. For example, Alicia described how she could only seek services for her daughters that were within close proximity to home and to public transportation. This significantly limited her options. She also emphasized that she had to work, that if she had to work, it would be impossible to manage the care of her daughters, her two daughters. And the time lost when caregivers have to rely on public transportation is also tremendous. On various occasions, I recall seeing young mothers at the clinic waiting for the Medicaid transportation service, sometimes for more than an hour. This was troubling to witness, since most clinic visits can take about 2 or 3 hours. And to add time because of the constraints of public transportation, this can be very stressful, not only for the parent, but for the children too. Several of the mothers I interviewed shared with me their experience with the Medicaid transportation service, describing it as both unreliable and slow. Paula, who I mentioned before, described to me how this service sometimes doesn't pick you up. She states, or recalled, they took you to the location, but they didn't come back to get you. I can remember being downstairs at Hugh Spalding waiting for 6 hours and wondering, how in the world am I going to get home? We had just moved here, we didn't have a vehicle, and my husband had just started working. It was hard finding a job because you need a vehicle to drive to interviews. So that was a major issue. That became a huge problem. Paula finds the unreliability of this service extremely stressful because she has to coordinate ahead of time someone who can take care of her kids just in case she's running late. She also felt that she was at a disadvantage because on several occasions she was unable to take advantage of an appointment for services that may have just come up because of a cancellation. Or she can't get a ride, and I think you have to schedule 3 days in advance. The logistics of these types of situation only adds to the already complex situation of these caregivers' lives and the ability to navigate services. Caregivers who have to rely on public transportation also have to manage challenges of having a child with autism in public. So autism is often described as an invisible disability on the surface. Children with autism seem like other typical children, especially if they don't move their bodies or have stimming or make noises. Parents have reported getting blamed for being a bad parent or accused of not disciplining their child when their children have emotional or behavioral outbursts in public. This is compounded when people have to rely on public transportation, you can imagine. One grandmother, Frances, who was raising her 3-year-old grandson, shared with me how hard it was to take him on public transportation. She often feels judged by other people because her grandson is very active and occasionally has behavior tantrums. This is especially difficult because she relies on public transportation to get around town and consistently encounters people who just don't understand why her son is acting up, or grandson. As her grandson has gotten bigger, she now has to put him on a harness when they're traveling because he has a tendency to run off very quickly. And I know those of you who study autism, this is a big issue. You don't want to lose your child in MARTA, right? As one can imagine, this elicits not only stress, but stigmatizing responses, not to mention the stress caregivers have during these circumstances. Many children with autism are also very sensitive to loud noises, crowded spaces, particular odors, characteristics that are often associated with public transportation. Furthermore, children with autism often function better when their schedules are reliable and consistent, even in specific routes they travel to and from school or to and from the store. I began to think about these issues and challenges they must pose when taking public transportation from Sheila. Sheila is a Black mother who just moved to Atlanta with her 2 teenage daughters. Her 15-year-old daughter was diagnosed with autism, and when we met, she was experiencing hormonal changes, which had enhanced her daughter's behavioral issues, her anger and her anxiety. On several occasions, Sheila and her daughter could not reach the clinic appointment because her daughter refused to take public transportation. Sheila reflected on this time by passionately stating, "Sometimes I was having trouble with her getting on the train and on the bus. Sometimes she just doesn't want to ride. Since the doctor's been helping with the medicine, it's not been as bad before. Before, I couldn't even take her on the bus when there was a whole bunch of people because she would have episodes and she thought people were staring at her. I mean, I went through it," is what the mom described it. When I met Sheila, she was also living in public housing and told me that the first public housing accommodation they stayed in when they moved to Atlanta kicked them out because her daughter often made loud noises at night because of her autism. Sheila's story really brings a whole new dimension of the realities of autism for caregivers and their families who have neither reliable transportation or housing. The stakes of having a child with autism in Sheila's case and others are much greater and the needs more complex. Unfortunately for Sheila, she moved to Atlanta thinking that she would be able to get better services for her daughter based on knowledge that she read on the internet about Atlanta. She was clearly misinformed. In Pittsburgh, Pennsylvania, where she was from, her daughter was receiving wraparound services, including behavioral support, social skills, and various services in her school. In Atlanta, her experience thus far has been the opposite since she was still trying to get her daughters enrolled in school. The move also created a gap in her daughter's Medicaid insurance coverage, which resulted in multiple trips to the emergency room when her daughter became increasingly uncontrollable because she was not taking her medication for anxiety. So these stories really begin to make visible the complexity of Black women's lives who are raising a child with autism in a structurally unequal society. These narratives also reflect the embodied experience of living within structural and institutional forms of inequality that operate through the intersection and intersect with various forms of discrimination. Since most of the women I interview had to rely on public health insurance, I just want to conclude by highlighting the intersectional and gendered politics of Medicaid, which are evident in these and other stories from the sample. This is important because not only does the politics of Medicaid reflect the haves, the have-nots in American society, or the have-nots of American society who compose the program's clientele, it is intricately linked to issues of gender and race. For example, women are more likely than men to endure financial hardships, experience low-wage jobs that lack retirement and health benefits, and reside alone or in single-parent households. Marital status is a significant predictor of economic stability or security, and women are far less likely to be married than men. This is certainly turning out to be the case in my sample. Further, roughly 70% of adult Medicaid participants are women, and although Blacks compose 13% of the US population, they make up roughly 1/4 of the welfare medicine participants. The quality of care is also limited, as evident in a report by the Institute of Medicine, which reviewed more than 100 studies pertaining to minorities and medical care. They found that insurance status is strongly associated with quality of services. The privately insured tend to receive better care than those individuals who are insured through Medicaid. Even when certain racial minorities have access to low-income health programs, they consistently experience fewer diagnostic and other services than do other sectors of society. For the mothers and the grandmothers on Medicaid in this sample, the ripple effects of intersectional and structural constraints of Medicaid have most certainly affected the life trajectories of their children with autism, as well as many other health conditions. Many of the parents I talked to had their own health conditions, and this is certainly an area that I'm going to focus on in the future. Certainly, this is the tip of my analysis and preliminary, which warrants a closer look at Medicaid policies in different states across America, especially when taking Medicaid expansion into consideration and the possible implications of the extraction of Obamacare. These actions are, of course, just part of a historical tug-of-war of Medicaid between Democrats and Republican leaders over its policies, procedures, and especially funding and benefit levels. As expressed by the voices of women who shared these stories with me, the effects of such political debate impacts the lives of people in very, very serious ways. So these preliminary findings begin to offer alternative voices that disrupt the dominant narrative we have witnessed thus far of the experiences of parenting a child with autism. This analysis begins to highlight the various structural and institutional inequalities that shape disparities to autism diagnosis and services for low-income Black women who are navigating the complexities of autism services. It highlights various interlocking locations of social oppressions that cut across gender, class, and racial lines, which are experienced in different ways to represent an alternative warrior mother who has to challenge much larger structural constraints. It makes visible the invisible. It lifts up another voice, and it denotes the various ways in which race, class, and gender interact to shape multiple dimensions of Black women's experiences in raising a child with autism. Thank you.